Good evening, everyone. I'm Debbie Hill-Basell, and tonight we are going to be doing case list review. It's Sunday, August 21st, and let's just get started. The good news is the attendee number amount does tend to grow each time, and of course, as we get closer and closer to the actual boards taking place, sometimes we can have so many attendees on that our goal is to make sure that everyone has an opportunity to participate if they so desire. So with regards to that, when I do start to ask for volunteers, I'll kind of go through and say, okay, if you haven't been called on this month and would like to be called on, please raise your hand, etc. So we'll try to just make it where we can be as fair as possible. With regards to how to participate, most of you guys know this. I'll jump through it super quickly, but basically there's this little orange arrow right up in your upper right-hand part of your screen that will both open and close your panel. Most of you are using your microphones on your computer, so you don't need to do anything special, but there are some people who are using telephone. And if you are using the phone, if you click on use telephone, then you will get a phone number, an access code, and a PIN. With regards to participating, you'll just raise your hands when I ask for volunteers, and then I will unmute you on my end. And you just need to make sure you're unmuted on your end, which is the little circle underneath the orange arrow. There's a microphone in it. Just make sure it's green on your part. All right, with regards to just going to jump in and do the case list, I always like to do a little bit of just fun lecture stuff to begin with. So I just kind of randomly said, okay, I want to just pull out a couple of facts to throw at these guys tonight and just see if they're aware of it. All right, so there was a practice advisory that ACOG published in September of 2021 talking about the use of antenatal steroids and at what gestational age should we be giving it. And you guys remember that it used to be it was only from 24 weeks on, right? And then a couple of years ago, they're like, well, we can consider it at 23 and 0 in talking to our patients and make it a mutual informed decision making. So now there actually was, from this practice advisory, they looked at should you give or could you give antenatal steroids to the periviable fetus from 22 and 0 to 22 and 6. And what they say is if neonatal resuscitation is planned and would be done when that baby delivered, you would do resuscitation, then you can consider giving antenatal steroids to that periviable fetus at 22 and 0. And this is the ACOG practice advisory. I don't know that you'd even ever be asked this. This is really kind of a MFM question, but if they did ask you what's the youngest gestation that you would consider giving antenatal steroids, now you know that little piece of information. This is information I'm sure you guys are well aware of, and this was from the new CDC STI treatment guidelines from August of last year, where we upped our dose for treating gonorrhea to 500 milligrams IM of ceftriaxone. But some of you may not also be aware, because obesity is more and more of a problem in our country, that if your patient weighs greater than 150 kilograms, they do recommend you increase the dose to 1 gram. Now for chlamydia, remember it was so nice when we could just give a gram of azithromycin. They changed that for the non-pregnant women to 100 milligrams of doxycycline twice a day for 7 days is the preferred first-line treatment for a non-pregnant woman for the treatment of chlamydia. But why is that? So what they looked at is urogenital chlamydia is still adequately treated with a gram of azithromycin. What they found, it's the anal and oropharyngeal chlamydia is not adequately treated with the 1 gram of azithromycin, so it just still serves as another like reservoir for continued infection. So you can give a gram of azithromycin, say the patient's allergic to doxycycline, or you really don't think they are going to be compliant with the weeks long of treatment. You can give a gram of azithromycin, but chlamydia is preferred, and that's why. You can also give levofloxacin 500 milligrams daily for 7 days. In pregnancy, however, we don't give doxycycline, right? Especially in that second and third trimester, because of the teeth discoloration, etc. So in pregnancy, azithromycin 1 gram is the preferred agent, or you can give amoxicillin 500 milligrams 3 times a day for 7 days. So those are your little just fun information for tonight. So now I'm going to close this out and pull up the case list, and then I'm going to get some volunteers. Okay, so now if there's anyone who has not been called on during this month and would really like to be called on, please raise your hand. Let me just kind of scroll through here. Okay, well, it looks like then anyone who's wanted to be called on has been called on. All right, so let's just go ahead and I know what I'll do. If you've not been called on for your, here, Melissa, you were just getting ready to put your hand up. Let's just open it up. Whoever wants to be called on, put your hand up, and I'm going to do the best I can to get to everybody. All right, Melissa, you're like first on the draw here, so I think you're just self-muted. I'll wait for you to, there you go.
Hi.
Hey, how are you?
Great, how are you?
Good. All right. So do you have a particular case list or even a particular case you want to be questioned on?
Let's just go at random. Let's just pick anything from OB.
Anything from OB. And are you a generalist?
Generalist, yes.
Okay. All right. So let me just see here. Let's do the cerclage ones only because, Melissa, there's been a little bit of some, not changes, but a little bit of some stuff that they talk about. All right, let's talk about patient number, I guess they're pretty darn similar, except patient 9 actually did get a rescue cerclage. Well, let's do patient 9. Nope, I want patient 8. I'm going to go back there. Okay, 32-year-old G5P3 at 14 and 2. How was this history of cervical insufficiency? How was that diagnosed previously?
She was diagnosed with painless cervical dilation at 20 weeks with her first pregnancy. And so, and that ended in a loss. And so for her subsequent pregnancy after that, she had a cerclage placed at 14 weeks. And so based on her, it was based off of her first pregnancy with painless dilation at 20 weeks, resulting in a loss that was her history finding.
Okay, and so then in the subsequent pregnancy, she had a basically history-based cerclage placed at 14 weeks. And so then this is her third pregnancy since then?
Yes.
Okay, all right. So anyway, so again, based off of that, you're going to go ahead and put in a cerclage at 14 weeks and 2 days. So tell me, what about this preterm delivery? Is that something different than the 20-weeker you're trying to tell me about?
Yes. So actually, with her second pregnancy, in which she had a cerclage in place, she had preterm labor at 31 weeks and was dilating essentially with the cerclage like in place. But there was significant cervical dilation, and that provider at the time decided to, as far as with where things were going, and um, decided to cut the cerclage, and she subsequently delivered.
Okay, so in this case, then, with that history of a prior preterm delivery, so basically you have two different things going on here. One is the history of
Correct.
preterm delivery for which you recommended the IM progesterone, and then you have the cervical insufficiency for which you received a cervical cerclage, I can't even speak, sorry. Tell me, how did you counsel her with regards to her options with the history of the preterm delivery?
With the history of the preterm delivery, we discussed, uh, well, with the history of the preterm delivery, we discussed progesterone, weekly supplementation starting at 16 weeks. And I discussed with her that that was different than treatment from her prior pregnancy, but that this was due to her preterm labor that she had had, and that was a different factor than her previous history of her cervical insufficiency, um, and that so the patient was agreeable to doing that, in addition to having the cerclage placed prophylactically at 14 weeks.
Okay, so with regards to if somebody has a prior preterm delivery, do you is IM progesterone the only form of progesterone you offer them?
No, I offer IM progesterone first. However, I do offer, if they are apprehensive about that, I do offer vaginal progesterone as an alternative.
Yeah, because that most recent practice bulletin that came out, tell me what was the difference prior to this? When were we supposed to use vaginal progesterone? And they changed that in the most recent guidelines.
Vaginal progesterone was previously more just used for like shortened cervix, for cervical length, like 20 millimeters or less. Um, that it was more for something already, like something found as far as that. This newer practice bulletin talks about as an alternative to IM progesterone, and that's basically the gist of that.
Okay, so then at what gestational age are you going to remove the cerclage and when can she stop her IM progesterone?
So I have her stop the IM progesterone at 36 completed weeks of pregnancy, and I cut the cerclage out at 37 weeks.
Okay, and did you actually place the cerclage?
This patient, yes, I did.
Okay, some of the candidates, it's their MFMs that do it, and that's why. Do they give antibiotic? Do you give antibiotic prophylaxis when you place a cerclage?
No, I do not.
Okay, let's talk about this history of a leep. How do you counsel patients about a leep and how it can impact their pregnancy?
Um, I discussed with them with that with the principle behind with a leap, and that has altered their cervix, and potentially their that does slightly increase their chance for preterm delivery. That like at baseline, somebody's risk of preterm delivery may be 10 to 12%, but that history of procedures to the cervix can increase that more. Um, so although all of my patients do receive a cervical length screening around the time their anatomy ultrasound due to their slightly increased risk of possibility of preterm labor. I do monitor their cervix again at 16 weeks if they've had a previous leep in the past.
So if somebody's had a leep or a cold knife cone, in addition to doing the anatomy ultrasound cervical length, would you just routinely do cervical length surveillance? Like checking it every 2 weeks? Why or why not?
So I do that between 16 to 24 weeks. I believe, and recently that's come to my attention that as far as ACOG's stance on that, that was actually possibly more from recommendations from MFM providers, but that's not specifically necessary unless you have a documented short cervical length.
Okay, if somebody has, let's say they're not pregnant, they get a leap done or a cold knife cone, what's the optimal time that you should tell them they should wait before conceiving in order to allow that cervix to maximally heal?
At least 6 months.
Good. All right, I'm going to stop there. You did great. That's exactly right. So those were really the main topics I wanted to touch on, Melissa, that we're supposed to wait 6 months. It should be wait at least 6 months after a cold knife cone or a leap. The other thing with regards to the newest practice bulletin on the prediction and prevention of preterm delivery, they do look at the leap and the cold knife cones, and they say, although it seems to be associated with preterm delivery and maybe some cervical incompetence, maybe it's not really that. Maybe it's they kind of are real wishy-washy about it. But what they do say, we don't have any data to support doing anything more than doing the cervical length in the second trimester anatomy ultrasound. So I love the way you handled it, and this is what I would recommend you guys do is think with things that aren't typically a standard yet, always throw your MFM under the bus. And if there's any MFM candidates out there, I'm saying this very tongue in cheek. What I'm saying is if in your institution everybody does, wow, you had a leap or a cold knife cone, we do every 2 weeks cervical length surveillance. Even if ACOG says, well, really doesn't have any data that say you should, feel free to say, this is per the protocol of the MFMs at our institution. How are you supposed to argue with that? Say that, oh no, I'm smarter than the MFM and I'm just going to do what ACOG says. Does that make sense to you? Because it's fine, just like with COVID, there is no standard protocol of what we should do. Some MFMs put the moms who've had COVID in pregnancy on aspirin. Some start antenatal testing. Some do growth ultrasound. Some don't do any of the above. So if you have a certain thing that you do, and that's what you guys do, feel free to say, if this is what ACOG says, or let's say they push you. Let's say the examiner's pushing you, Melissa, and you don't really know what if ACOG does recommend that or not. Feel free to say, this is following the recommendations and the protocol of the MFMs at our institution, and then just shut up. Does that make sense? Oh, I lost you. How did I lose you? Attendee is muted by me. How did I mute you?
You got
Hey,
it.
are you there?
Thank you.
How?
I just wrote it wouldn't let me unmute and I messaged you.
Okay.
Yes, it makes
I'm
sense.
like, where'd you go? Where'd you go? Okay, yeah. So that's just another kind of an exam tip. So that was great, and you knew that you should wait 6 months. So I'm delighted. Great. And
Thank
you don't
you.
give antibiotics, and your removal and everything was good. So good job, Melissa. Thank you, Matt. Hey, Matt, how are you?
Hi, good. How are you?
I'm fine. Let me find you.
Good.
Any particular case or case list you would like to do?
Maybe GYN, but I don't have a particular case on there necessarily.
Okay, and are you a generalist?
Yes.
Alrighty. So let me just see if I can find something fascinating. Let's look at this one. This is kind of filled with all kinds of good stuff. So it's a young age hysterectomy because she's less than 40. And let's see here. We've got some good old chronic pelvic pain, all kinds of good stuff in here. All right, so you've got this patient with abnormal bleeding, chronic pelvic pain. How did you know she had endometriosis?
So that actually came later. That came with her diagnostic laparoscopy. She came
Okay,
to
so
me.
go ahead.
Sorry. Oh, I was just going to
No,
say her initial appointment with me was left-sided chronic pelvic pain. And after her diagnostic laparoscopy, that's when the diagnosis of endometriosis was confirmed.
Okay, so she comes in to see you with basically chronic pelvic pain as her main complaint and also some abnormal bleeding. So tell me in your head, what was your differential diagnosis? And then tell me how you kind of work through her evaluation. But let's start with differential diagnosis first.
Sure. So I typically break it up by system when I approach something as generalized as chronic pelvic pain. So with gastrointestinal, I typically think of irritable bowel syndrome, inflammatory bowel disease, chronic constipation. With regard to urological symptoms, or excuse me, differential, I think of is interstitial cystitis, nephrolithiasis, urinary tract infection, and then of course with female pelvic, and then generally speaking, I also think of like musculoskeletal etiologies like a strained muscle, something along those lines. And then with female gynecologic origins, I think of obviously endometriosis. I think of like a ruptured ovarian cyst. I think of mid-cyclic pelvic pain. Or ovulatory pain. I think of adenomyosis, which is on the spectrum of endometriosis as well. Those are kind of the main ones that I think about.
All right. So when obviously when she comes in, the history is going to be really important to with what you do. When did it start? What reproduces it, etc. Tell me how you do a physical exam on someone with chronic pelvic pain to see if you can elicit or reproduce the pain that she's describing.
Sure. So I first do an abdominal exam, ruling out any abdominal masses, any point tenderness, any sort of musculoskeletal pain that might be more superficial rather than deep. And then I do a genitourinary exam. So I do a speculum exam to evaluate for any lesions or masses after initially doing an exam for the external genitalia, looking at the urethral meatus and looking at the labia. And then I perform, typically after a speculum exam, I'll perform a bimanual exam, evaluating for any ovarian masses if I can, and any cervical motion tenderness.
In this patient, do you recall, was there anything on pelvic exam that was suggestive of endometriosis to you?
Suggestive for her was she complained of left-sided pelvic pain. So on bimanual exam, she noted it was more on the abdomen. On abdominal exam, she had more left-sided pelvic pain and no suprapubic tenderness. So more left-sided pelvic tenderness.
What else could cause pain over there in that left lower quadrant?
Constipation, diverticulitis, diverticulosis, gas pain.
What's another real common one in a younger woman, 39? was one of the most common GI causes of chronic pelvic pain?
Constipation?
All right, that's not what I'm, irritable bowel.
Oh, okay, sure.
Yeah, so seriously, of the four most common chronic pelvic pains or causes of chronic pelvic pain, but I'm going to add a fifth one now that we know how much pelvic floor dysfunction is. It's endometriosis, pelvic adhesions, irritable bowel syndrome, interstitial cystitis, and I'm going to add, on top of that, almost anytime you have chronic pelvic pain, you can oftentimes find some degree of pelvic floor dysfunction. So IBS typically presents with that left lower quadrant pain also. All right, so what else could be indicative or suggestive of endometriosis on a pelvic exam, just in general? What about, go ahead.
I can't think of anything right now.
Okay. What about like uterosacral ligament nodularity and tenderness, maybe like a retroverted frozen pelvis that you can't really, so those would be things that classic would be the uterosacral ligament nodularity and tenderness, because that you're in the deepest part of the posterior cul-de-sac, and we tend to see endometriosis there a lot. Okay. All right, so anyway, so now you did your physical exam. Oh, the other thing too to add into your physical exam is that to do a one finger vaginal exam where you truly are going around pushing on the levator muscles, checking to see if you can reproduce the pain by palpation of the bladder, etc. So that's just one more part of the exam. All right, so now you've got chronic pelvic pain. You did an ultrasound that looks normal. So your working diagnosis, you're thinking, is probably endometriosis. Why were OCPs contraindicated in this woman?
This patient had a history of OCP use, and she had a hypertensive, like essential crisis after using them, and had to go to the emergency room for antihypertensives.
Okay, well, so what medical management did you try on her?
So we had tried progesterone-only medications. We had tried cyclic NSAIDs around the time of her menstruation. She had previously tried an IUD that did not relieve her pain. She did not want to trial any sort of GnRH agonist or antagonist.
Okay, so then you're like, okay, with the abnormal bleeding, you did the ultrasound, she's failed medical therapy, both pain and bleeding wise. You take her to the OR, do a diagnostic laparoscopy, and also do a hysteroscopy DNC, which the DNC comes back benign. And then on laparoscopy, you see endometriosis. And now that you have a diagnosis of endometriosis, when you went back, did you discuss with her the GnRH medications?
We did. She had some significant. She has chronic pain elsewhere as well, and has had to miss work multiple times. And she did not feel like she wanted to trial any sort of kind of management that would require trial and error, essentially.
Gotcha. All right, makes sense. All right, so now you're going to go give her definitive therapy for the chronic pelvic pain portion that you feel is due to her endometriosis. So tell me, I guess, why did you remove the left ovary, or why'd you leave the right? Tell me how you made the decision of what you did with her ovaries.
So on diagnostic laparoscopy, since her pain was always left-sided, on diagnostic laparoscopy, I noted multiple endometriosis implants along that left ovary. It was extensively just covered in implants. And given that her pain was left-sided, we discussed possibly unilateral oophorectomy on that left side, which the patient was amenable in order to try and alleviate this pain. So the right ovary on diagnostic laparoscopy looked normal and without endometriosis implants. So the decision was made to do a unilateral oophorectomy at the time of her hysterectomy, because we would like to, wanted to leave her with endogenous estrogen in order to decrease the risk of all-cause mortality and other potential side effects or adverse effects of she also didn't want to do any medications after this, if at all possible. So she felt like she wanted to trial,
Okay.
like as far as like add back therapy. So she wanted to
So
trial it.
what would you have done, even though her pain was primarily left-sided? What if you looked and her right ovary did have little studdings of endometriosis on it? What would you have done?
I would have well, if this was intraoperative, I would have left the right ovary typically and discussed it with her. But if it was preoperatively, as far as seeing it on the diagnostic laparoscopy, I would have discussed that there were endometriosis implants on both ovaries, and she may or may not benefit from a bilateral oophorectomy, but typically with a patient less than 40 years old, I would be very hesitant to do a bilateral oophorectomy.
Yeah, and if you had to have done that, let's say there were bilateral endometriomas, it was stuck to the pelvic sidewall, etc., and there was no way to save her ovaries, what would you do, and what does even ACOG recommend you do with regards to estrogen therapy postoperatively for a 39-year-old surgical menopause patient?
So yes, so if I were to do a bilateral oophorectomy in this patient, I would have likely offered her the option of receiving estrogen therapy to decrease bone mineral, certain side effects of loss of endogenous estrogen. That includes like loss of bone mineral density, cardiovascular events, hyperlipidemia. So we would have done micronized estrogen if she had been amenable to this.
So micronized, or you mean transdermal?
Sorry, transdermal, yes.
Okay. All right. All right. So good. So I'm just going to let you take a deep breath there for a second. Only reason because I brought this one up is chronic pelvic pain is on everybody's GYN case list. And so if they ask you like what's your differential diagnosis of chronic pelvic pain, a nice way to do it is one of the ways. I'm trying to say 17 things at one time, sorry, which is I would do terrible at an oral test, right? Because I'm trying to say too many things. Okay, so try to think of it when you're talking to the examiner that you're almost doing an outline version, and like you're starting at 30,000 feet, giving the general picture, and then you're ratcheting down. And what I mean by this is my differential diagnosis of chronic pelvic pain, I'm going to think of GYN and non-GYN causes. So you're showing the examiner right from the get-go, you get the big picture. It's not only GYN. Then you could say of the GYN causes, I'm thinking of endometriosis, leiomyomatous uterus, chronic PID. I mean, the list goes on and on. Of the non-GYN causes, I'm thinking about GI causes, GU causes, musculoskeletal causes, and psych. And then you can even go and fill in some of those. It's just a way to help keep you organized when there's a huge differential, because it's really tough to go, well, it could be constipation, it could be depression, it could be endometriosis, and then it's so easy to get so confused. Whereas if you kind of structure it for yourself that you can stay you're organizing your answer as you're giving it. Then who cares if you forget some of the fine points? You've already showed them, you get the big picture. So I love that part. Okay, so anyway, so you did a nice job on what her medical management, why her OCPs were contraindicated. My question though, and so then with regards to the definitive treatment for endometriosis, in my days when I was training, like we would, if you did this for an endometriosis case for chronic pelvic pain, they would have told us we did an inadequate procedure by leaving an ovary there. But we've come a long way since, and now even ACOG says when you do a hysterectomy for chronic pelvic pain due to endometriosis, it is reasonable to leave one or both ovaries if they look normal. There's no endometriosis, no endometriomas, etc. As long as the patient understands she's got about a 30% chance you may have to go in the future and remove that ovary, but that also means she's got a 60 to 70% chance that she will never need that ovary removed, and of course the benefit of her endogenous hormones. But ACOG does say if you take out the ovaries of a premenopausal woman, not you can consider, you should give her estrogen therapy until the average age of menopause. So it's not saying, oh, well, maybe you should take estrogen. No, you should. And it should really be double the dose you would give a menopausal woman, because you're really, like if you put a menopausal woman on, say, 0.05 milligram per day estradiol patch, they'd want you to put this woman on a milligram, because we're trying to put back some physiologic doses. But I think you did great management. I love the fact that the left ovary with the left lower quadrant pain, etc. And tell me why you sent her to pelvic floor physical therapy afterwards. I thought that was excellent also.
I typically do that with a lot of my pelvic pain patients, just because we have a great pelvic floor program here, and they may have some spastic pelvic floor syndrome or pelvic floor disorder after so long of such a long time of having chronic pelvic pain.
100%. That it, just like you can get secondary vaginismus, that the spasms occur after whatever the painful event was. Same thing with chronic pelvic pain. Many times, pelvic floor dysfunction, levator spasms may be secondary to something else, but they've been in pain for so long. And then, of course, the other big question they could ask you is, why did you choose to do this robotically?
At my institution, we have significant availability of robots, and given her pelvic pain, we decided against, and also the preoperative decision to likely take the left ovary, we decided against doing any sort of vaginal hysterectomy. So robotically, I'm more comfortable with a robot to do that as far as laparoscopic surgery goes.
Okay, so let's do a little bit, not even so much just that you're comfortable. Let's toot the horn of the robot. That it would be, this was an endometriosis case. This gave me magnification. This patient was not a candidate for, you could just say this patient was not a candidate for TVH because of her endometriosis, the left adnexa, etc. The reason I chose a robot versus a straight stick lap, and then you could go into everything that the robot does, magnification, the articulation, easier to get other, endometriosis, etc. So you don't even have to say so much that you feel more comfortable of it, but speak to, like, I'm comfortable with everything, and this is why I chose this, because this is where the robot stands out. Does that make sense?
Yes, thank you.
Okay, all right, good job, thanks.
Thanks.
All right, I'm gonna mute. I think Danielle, I saw, had a hand up. Let's get to her. Hey, Daniela, how are you?
I'm good. How are you?
Good. Did I say your name right?
I think they have a typo on my name and it says Daniela, but it's actually just Danielle.
Oh, okay. Yeah, you're Daniela.
Yeah, I'm just Danielle.
You have a typo. You're like, I'm just Danielle. Just call me that.
Yeah.
All right. So let's pull up your case list. Are you a generalist?
A generalist.
Okay, all right. What case list would you like to do?
So I had a specific case I wanted to do just because it's not very common and I want to see what I need to know and practice it.
Sure.
It's
No,
on
that's
the
good.
OB.
And seriously, okay, perfect. And I just want all of you guys to know, and all of us as faculty are open to that. When we call on you for structured cases, excuse me, for case list review, if you're like, there's a, sometimes the candidates will be like, I had a really bad outcome. I'm really nervous about it. I'd like you to ask me about it or walk through it. And, all of us have had cases that didn't turn out the way that we'd like to. So don't feel judged and feel free to bring those up. All right. So tell me where we need to go, Danielle.
It's patient number 34.
All right. All right, so let's see here. So she had a complete septate uterus with a longitudinal vaginal septum. Okay, so when she comes in having already conceived at your new OB visit, right? And that's when the longitudinal vaginal septum was diagnosed. Nobody had ever diagnosed it previously.
So she was actually seen and known to have at least the vaginal septum portion and was referred to REI for evaluation of infertility and then spontaneously became pregnant.
Okay, and because typically with the septate uterus, what do we worry about in pregnancy?
Oftentimes they'll have high risk for spontaneous abortion or miscarriage.
Yeah, that's one of the things we look at with recurrent pregnancy loss, right? If there's a septum, the implantation just fails again and again and again if it implants on the septum. Now, with regards to a complete septate uterus, so that's interesting. So they're not even saying it was like bicornuate, so or anything. It was truly a septum. And the vaginal septum was what, the upper 2/3?
The vaginal septum actually came all the way down to the introitus, so it's complete.
Wow, that is interesting because that's like two totally different development tissues. All right, but anyway, so with that in place, so her cervix is what, on both sides of that?
Yes,
Okay.
and
So
one
what
cervix.
was Yeah, so one cervix, yeah. So it's not like a bicollis uterus with the septum, and she's got two different cervices, one on each side. There's one cervix, and is the cervix totally on one side of the septum, or is the septum coming half, like right in between the cervix? I'm trying to picture this in my head.
It's pretty much midline. So
Okay,
the
all right.
cervix
So
is not clearly visualized on one side or the other.
Okay, so why was the thought that she could even have a vaginal delivery with this septum?
So with this, there was obviously that concern, which was discussed with the reproductive endocrinology and infertility specialist to see whether it was feasible or thought that she could have a vaginal delivery. And they had recommended her at least have a trial of a vaginal delivery, as they thought that the septum would push out of the way with the presenting part.
Okay, and if it didn't, I guess they're thinking what you would do a section, or
You would do a C-section.
it would just tear and you would have to repair it afterwards, because it's pretty unlikely that septum to me would be intact after a vaginal delivery.
They thought that it was thin enough that it would be able to push off to the side
Okay.
and she would still have a vaginal delivery, but all of those questions were brought up.
Okay, all right. So again, REI, and this is another thing where you defer to the judgment of the specialist. REI is who evaluated this patient, and tell them she was going for infertility. She spontaneously conceived. They were comfortable with that. They felt the septum was thin enough, and the way it was placed, it would basically push out of the way from the from the fetal vertex, and she should be able to have a vaginal delivery. Now, with this complete septum in the uterus, and that baby was big. So did the septum just again push out of the way as the baby developed?
Yes, the septum did higher up anyway.
Okay, all right. So anyway, so she goes into spontaneous labor, has a vaginal delivery, has a retained placenta. And do you think that was because of the septum in the uterus or the vaginal septum, or who the heck knows?
I think the septum could contribute, but it was also a fundally located placenta, so
Okay,
it's
all of the above.
multifactorial.
Okay, so anyway, so then you manually extract the placenta, and then tell me what happened with the hemorrhage.
So after the placenta was manually extracted, I did uterine massage, and because there was some initial atony, but then that improved. I did a thorough vaginal exam, and it was at that point that I noticed the the inferior aspect of the vaginal septum had in fact torn.
Okay.
So at that point in time, because we are able to necessarily do these on our labor and delivery, I placed a Foley because the bleeding from the uterus was improved. I placed a Foley, and then I placed packing to help tamponade the vaginal septum while we were in transport to the OR.
Okay, and so then you get her under anesthesia. Then tell me how you evaluated her, what you saw, and what you repaired.
So in the OR, I removed the packing, the Foley was kept in, and I did a thorough vaginal exam again while the patient was more comfortable. At that point in time, I did notice that the vaginal septum at the inferior aspect did actually tear, and it did track up towards the cervix. So I also at that time ran the cervix to assure that there was no cervical laceration at that time, which none was found. And then I repaired the vaginal epithelium and resected the remaining portion of the vaginal septum that was bleeding.
Okay, and then bleeding stopped, correct?
Yes.
Okay, good. And tell me why you gave her some antibiotics. What was the thought for that?
I felt that she had an increased risk for infection given the retained placenta, and on top of it, the 1500 EBL blood loss. So I thought her risk was high enough to warrant IV antibiotics.
In general, when we do manual removal of the placenta, is that something that is that a dose of antibiotics is indicated for?
My understanding is that it's neither supported or completely refuted.
Okay. Yeah, I think ACOG says it's not necessary, but it's a commonly performed procedure. But let me tell you why else I would do it. You had a pretty, again, you had that whole back wall of the vagina you had to repair. We do know for third and fourth degree perineal lacerations that one dose of prophylactic antibiotic helps to reduce the chance of wound infection and breakdown. I think that would be a reasonable thing in this case also. Do you see what I'm saying? So I'm fine with you having given it, but you could perhaps even tie it into that. And then you gave her a unit of packed blood cells. So yeah, I think the big thing here would be they'd say, wow, why did you think with this septate uterus and a vaginal vaginal septum that she would even be a candidate for a vaginal delivery. And then you could describe what REI said, that you agreed with it, that the patient was counseled, that she agreed with it, and that basically everything went fine, even with the pregnancy. And then it really was just the septum itself did indeed tear, and you had to take her to, with the retained placenta. That was one thing, but then with the tear, you did EUA and repaired it. So are you comfortable with presenting that now? Here's would
Yes,
be
I
my
think so.
big question. Now that she's got that big complete septate uterus, she obviously had a term pregnancy and that was fine. I guess the question would be, so is REI going to resect that septum or just let her see if she can get pregnant again? And that's going to have to be their judgment call.
Right. I think for her, because of the fact you repair it post, like she wasn't repaired postpartum, it was, during delivery, she's
No,
gonna
no,
need to reevaluate.
I mean her uterine septum.
Oh, if they're gonna do that.
The up in the uterus, yeah, not
Right.
her vaginal, but the uterus septum. Because did you resect the entire septum, or did you just take the part that had torn, just just left the other part intact and then just repaired what tore? Correct?
I just repaired what tore because everything was so
Okay.
edematous. It's real hard to
Oh, absolutely. I
do
totally
that.
get that. Yeah, I was thinking of her uterine septum. I'm like, I
Yeah, I
wonder what
left
they're
that.
going to do with that. Yeah, so that'll be on them. But no,
Yep.
I think if you just walk through that, and again, you did all the right stuff with regards to the quote expert, getting the opinion of them, and the patient was in agreement. So interesting case. So thank you for sharing that with us. Do you have any questions for me? They could
No,
ask you again, be prepared to discuss what causes a septum, and that the uterus doesn't hollow out properly, and go
right.
into the whole mullerian and the didelphys versus the arcuate versus the septum. Just make sure that you can say a couple of sentences about that.
And that's my main question for something like this. Um, I guess what level of detail would they want me to know about the embryology? I mean, other than,
Yeah.
Mullerian ducts, they come together, either are complete or incomplete, and then you get the hollowing out. Is
Mm-hmm.
there much more than that?
Let's look at it. They may ask you again, what percentage of these patients have some sort of a associated renal abnormality? Has anybody looked at her kidneys? Have you?
They had not yet.
Yeah, because do you know what percentage of patients who have genital tract abnormalities also have associated renal tract abnormalities?
It's often times like 20 to 30%, 40%
Yeah.
if it's unicornuate.
Yeah, so absolutely. So that's great. So that would be the thing too, that this patient should have had, because they could have even just done an ultrasound even when they were doing it, just at least to see if she had both kidneys, or if they could see duplication of the ureters or something. So I think as long as you know that you can also have associated renal anomalies, and you don't need to be able to go to the craziest, like bicornuate, bicollis with whatever, but you should be able to give basic embryology, because this is not an REI test, okay? And they've only got 30 minutes to review your OB case list, and you have 22 pages worth of stuff. Do you know what I mean?
Okay.
So they're not going to spend tons of time on grilling you down on embryology.
Okay.
All right, so good. Well, thank you for bringing that to our attention. We're all glad that one's not on our case list. No, I'm teasing you. I'm teasing you. You at least know what to look up a few things, and you will do just fine on that.
Okay. Thank you.
Thanks. All right, and I saw one other person. Hang on. I think Jessica. Hey, Jessica, I think I unmuted you, so it might be on. Yeah, there you go.
I think I got it. Thank you.
How you doing?
I'm well, thank you. How are you?
I'm just groovy. So you tell me what case list you would like to do.
Can we do dealer's choice, please?
Alrighty. And are you a generalist?
Yes.
All right, we haven't done office yet. All right, I'm gonna throw something at you just real quickly, Jessica, just again on a teaching thing. Let's say let me see if you've got this. All right, like patient number 3, here's your dyspareunia patient, okay? And then this patient unfortunately also had a history of sexual abuse, but let's say you had someone that she complained of introital dyspareunia, you did her workup, you did the Q-tip test, all that kind of stuff, evaluated, ruled out other causes, and you diagnosed her with what?
Vestibulitis?
No, we can't call it that anymore. I'm trying to think of the right term. Localized vestibulovulvodynia. I don't know. I grew up calling it vulvar vestibulitis, which I think makes way more sense, but it's localized vestibulodynia or something like that. It doesn't matter. But let's just say it's vulvar vestibulitis. You try her on topical therapies, you try her on physical therapy, you've exhausted everything, and the patient, and you say, really, the only thing that I could think to offer you would be a vestibulectomy. If the examiner asked you, how do you do a vestibulectomy? And you had just told the person that would be the last thing you could offer her, would you know how to answer that?
I have an idea because I saw one as a resident, but I've never done one myself.
Okay, so what would, if the examiner said to you, so how do you do a vestibulectomy? Describe it to me, Dr. Schneider. Is it Schneider or Schneider?
Neither.
Schneider, Dr. Schneider.
Yes. So I would, prior to bringing her to the OR, I would do an exam with the Q-tip again so that I could mark the whole area that was painful for her. And then when we went back to the operating room after she was anesthetized, I would use my markings as a guide for the excision after I inject some local anesthesia. I would excise the area. Honestly, I wouldn't go very deeply. And then I would close with interrupted sutures.
Okay, all right, so that was excellent. And because you had actually seen it done, that was a great description. So if I was working with another candidate and we went over this and he was like, whoa, I'm not sure, then, kind of fumbled. So here's the thing. If they ask you, if you're describing something, say, well, the next step would be to do a X, Y, or Z, and you personally have never done it, you just know that's the next step, own it right up the front. I've never done a vestibulectomy. I know that would be the next thing to offer the patient. So I have two options. One, I could either send her to UroGyn or one of the pelvic floor fellows who would have more experience with this. But if I was the only person in the area that could do it, I would review ahead of time exactly what I need to do this. But the basic premise is I'm going to need to mark and remove the area of the vestibule, just the layer of epithelium that's tender. Do you see what I'm saying? What my point is, you don't have to sit there and go, I have no idea. You can still say, I've actually never done one. If I was to do it, I would obviously look it up, re-review what the steps were, etc. My preference would be to refer them to somebody who has done many of those. And that's fine. We're generalists. We don't have to do everything. So that is an acceptable answer to own right up the fact from the beginning that you've never done it. Does that make sense? So just don't be afraid to do that, but then say what you would do in order to remedy the situation for the patient. All right, so now let me find you something I can ask you about. But thank you for that. And that was a very good one that you answered. Let's look at patient number 34. So there's an 80-year-old that comes in to see you. I'm sure she didn't say, hey, I have a cystocele, but she probably said what? I've got like a bulge or a discomfort or a heaviness, something like that.
She told me there was something coming out of her vagina.
Okay, so when you examined her, tell me, how did you determine what was prolapsing? What was the pelvic prolapse that was going on?
Sure. So I started by just separating her labia and having her bear down and seeing what moved, and what I could see if anything came all the way to the introitus. And something did come to her introitus, but I wasn't sure what yet. So I put in a speculum and I took a look at her cervix. I had her bear down. Her cervix did move a little bit, but not to her introitus. So I did a split speculum exam and had her bear down while first depressing the rectum and then after that depressing the bladder. And I was able to see that it was mostly her bladder moving with a little bit of an apical component.
Okay, so once now, and how would you have, do you grade it or do you stage your degrees of pelvic organ prolapse?
I staged it.
You stage, okay, so what stage was this?
It was stage 2.
It was a stage 2, all right. So then, tell me how you counseled her about what her options were.
So first I counseled her on expectant management, which would be doing not a lot. Then I counseled her on pelvic floor physical therapy. I counseled her on pessary, and I counseled her on surgical management.
Okay, go ahead.
Nope, those are the 4 things I counseled her on.
Okay, and so she obviously chose conservative therapy with both pelvic floor physical therapy as well as a pessary. So let's talk about the pessary. How did you determine what pessary would be a reasonable choice for this patient?
Sure. So I only really fit 2 shapes. I fit rings and I fit Gellhorns. And because there was no rectocele component and she had good perineal support, I thought a ring would be a better choice for her. We do
Okay.
have a pessary fit kit in our office. So I went through, I did a bimanual exam. I kind of gauged how wide her vagina was, and I went to the pessary fit kit and chose a few sizes out of there to give a shot with, and wound up finding the appropriate size for her, with which, if I recall, might have been a number 3.
All right, so now you fit her for the pessary, and is she capable of inserting it and removing it, or is she going to come back to see you every couple of months for pessary maintenance?
She's going to come see me every 3 months for maintenance.
When do you give estrogen therapy for these patients?
I
Vaginal estrogen.
give estrogen therapy if they have discomfort with like atrophic discomfort prior to seeing me. Like sometimes they'll say, oh, I have vaginal dryness as well, and that's part of the history taking. I'll also give them estrogen if they are many years removed from menopause, as this patient was. And if they have a pessary erosion, I'll use estrogen to treat it.
Okay, and so did you put her on estrogen therapy?
I offered it to her, she declined.
Okay, all right, so you did that, and then with the pelvic floor physical therapy, so what does I've never done this with somebody with a pessary using it. So does PT take the pessary out and then they reinsert it, or how do they do their physical therapy with the pessary?
So to my understanding, and after talking with this patient, some sessions are done with the pessary in place and some sessions are done with the pessary removed. And our physical therapists here do clean them and replace them and remove them as well.
Okay,
I
all
don't
right, good.
because I really don't know enough about what physical therapists do.
Okay, with regards to at what grade of cystocele would you be concerned about excessive post-void residual?
I would be concerned at stage 3 or greater.
Okay, and what would be an abnormal post-void residual?
Greater than 25% of the voided volume.
Okay, or if I was just looking at a CC, could you give me a CC amount?
I can't.
Okay, usually we say for sure if it's 150 or greater, that would be abnormal. What if
Okay.
you put the pessary in and all of a sudden the patient develops stress incontinence?
That's actually something I talked to them about. I talked to them about restoring the normal anatomy, putting different stress on the muscles that support the bladder and the urethra, which can cause a stress incontinence in response to having restored normal anatomy.
Okay, all right, good. I don't have any other questions for you on that. Do you have any questions for me?
What was the right answer about the estrogen?
What you said is just perfect.
Okay.
Anybody who's estrogen deficient, like an 80-year-old, is going to have very thin tissue. I know she's going to get a better result, meaning less erosions, um, uh, less just irritation and stuff if I re-estrogenize her vagina. I don't know if this patient's had any problems with UTIs, but now I'm going to go put a pessary up in there, just adding a foreign body. I'm thinking that that would help with reducing, possibility of UTIs, etc. So truthfully, anyone I'm going to do a pessary, if they'll accept vaginal estrogen, I will give it.
Excellent.
So
Thank you.
I think that's a reasonable thing. So thank you you did a great job. I have nothing to give you advice about with regards to your exam style. So you did a great job. Thanks,
Thank you.
Jessica.
I appreciate it.
All right, well, that is it for tonight. Sorry, the people I didn't get to, but we'll get you next time. All right, thanks, guys.